Hello, everyone. My name is Dr. Ken Shaskas. Next slide, please. And I am Senior Program Officer at the Foundation for Opioid Response Efforts, or FOR. I'm honored and excited to open today's important event that will highlight promising global practices and policies for treating opioid use disorder, preventing harm, and promoting social justice that we have learned during the COVID-19 pandemic. A note to start, you can enable language interpretation by clicking on the globe image on the bottom right of your screen, and you'll be able to select English, French, or Spanish. If you're joining through a phone, click on the three dots, scroll down, and you'll be able to select language interpretation there. But first, next slide, please. First, for those who don't know us, FOR was launched in 2018 as a new private national grant-making foundation focused on supporting and accelerating solutions to the opioid and overdose crisis. Our mission is to convene and support partners advancing patient-centered, evidence-based solutions along the themes of our 4 Ps. You can see them here: professional education, payer and provider strategies, policy initiatives, and public awareness. Next slide, please. Since our founding in 2018, we're proud to date to have awarded 64 grants totaling $28.8 million to 58 organizations across the United States. 4 grant-making programs to date have focused on a number of areas, including access to treatment for vulnerable populations, responding to the COVID-19 pandemic through recovery services and evaluation of relaxed regulatory policies, which we'll talk a little bit about it today. An innovation challenge to tackle some of the opioid crisis most intractable problems, such as stigma, as well as generating more timely and actionable data, and a family and community-based prevention program for children and families at highest risk. Next slide, please. This webinar is going to highlight one of our COVID-19 response grants. The pandemic brought new challenges, but it also magnified already persistent issues related to the opioid and overdose crisis. Right away, we saw an incredible need to focus on innovative virtual recovery support services, particularly for vulnerable populations, as stay-at-home orders and social distancing measures were put in place. And you can see here our first 2 waves of funding really focused on bolstering these services. But additionally, we wanted to leverage opportunities to inform future policy and practice as pandemic regulatory relaxations around opioid use disorder treatment, such as take-home methadone doses, were being implemented. So we funded several projects to assess the impact of these relaxations and policy changes that were aimed at ensuring access to care, with the goal to inform future US policies to improve access and promote equity for the treatment of opioid and substance use disorder. Next slide, please. One of those projects was with Dr. Helena Hansen and the Substance Use COVID-19 Data Collaborative housed at the University of California, Los Angeles. This international collaborative of social scientists, community researchers, and public health clinicians have been pooling data, collecting field reports on grassroots innovations and social policies around the world during the pandemic. The collaborative's work to date culminates today with the release of a special supplement of the American Journal of Public Health, which we encourage you to check out, and you'll hear a little bit more about in a second. You will hear about some of this work today as collaborative members showcase best practices and policies for promoting access to treatment and harm reduction services during the pandemic and potentially beyond, as well as other lessons drawn from the International Data Collaborative. Next slide, please. This is FOR's first project, and only so far, of supporting learning from international models and experiences. We are so pleased to have provided funding to Dr. Hansen and this incredible group of researchers you'll hear from all around the world. Sharing lessons learned across different countries can help inform and enrich all of our work, and we at FOR are proud to be supporting this effort. We look forward to what we expect will be a thought-provoking day. Thank you and enjoy the day.
Hello, everybody. My name is Marie-Geoffrey Roustide. I am a research fellow at the French National Institute of Health and Medical Research in Paris, in France, and I'm also very happy to be here today with all these fantastic speakers. So I will briefly present our Substance Use and COVID Data Collaborative. So this collaborative was formed in May 2020 as a network of social scientists, community researchers, and organizers. We also have some clinicians with field data. And we decided in this collaborative to gather field data on the impact of COVID-19 on drug policy, people who use drugs, treatment, and harm reduction organization. In this collaborative, we have 59 members from 14 countries in North and South America, Europe, the Middle East, Africa, and Asia. We implemented 3 working groups focused on new research, policy advocacy, and media, and each group meet monthly to work on multiple projects. I also want to thank our financial support, so the Foundation for Opioid Response Efforts, the Open Society Foundation, the US National Institute of Health, the UCLA and Yale Schools of Medicine, l'École des hautes études en sciences sociales, and la Mission interministérielle de lutte contre les drogues et les conduites addictives, and the Canadian Institute of Health. So for technical assistance, I also want to thank US National Academy of Medicine, the International Society for Addiction Medicine, and the Drug Policy Alliance. So a lot of members of the collaborative published several articles in our American Journal of Public Health special supplement that was launched on the website of AGPH on March 29, so yesterday. And just a reminder that for people who are French or Spanish native speaker, it's possible to have a simultaneous interpretation when you click on the bottom of your screen on the globe with the name interpretation. Thank you and enjoy the webinar.
Hi, everyone. Thank you so much for joining us. I'm pleased to help launch this event's critical in launching the new supplement that's been mentioned in the American Journal of Public Health, for which I've just posted the link into the chat. This supplement, representing 20 articles, includes 7 research articles, 11 editorials, and 2 analytic essays that bring together emerging, critical, and often justice-oriented practices in relation to addressing drug-related harms from around the world. And really, this supplement sought to accomplish 4 key aims. 1, to highlight innovative and evidence-based and grassroots approaches, such as peer-led harm reduction approaches that have previously been marginalized within drug policy debates and within intervention, particularly in the United States, to spotlight specifically social scientific, ethnographic, and community-based research that often doesn't make its way into mainstream medical and public health journals, to really emphasize the moment that we're in. We're in this critical context in the United States where we've lost more than 100,000 people to overdose deaths in the past year, and there's a critical need to re-examine policies and embrace evidence-based approaches from around the globe to address the severe social suffering produced by the overdose crisis. And then finally, to bring together work that applies intersectional approaches that consider how structural inequities on the basis of, for example, race, class, gender, immigration status, shape vulnerability to drug-related harms and overdose. So the work within the supplement is clustered around a handful of key topic areas that focus around operationalizing harm reduction, the context that we're in of a rapidly shifting drug supply that is exacerbating overdose vulnerability and producing untold deaths, a push to learn from global experiences, including experiments in decriminalization and safer supply approaches, to look at integrated models of treatment, harm reduction, and recovery. And then finally, and always, to foreground racial and social justice and grassroots leadership in approaches to the overdose crisis. We hope that you visit the issue, engage with the work, and are so thankful that you're able to join us today as we launch this supplement and bring together a wonderful group of speakers from around the world. Thank you.
Hi, good morning, everyone. My name is Jennifer Carroll. I'm a medical anthropologist from North Carolina State University. I'm coming to you this morning from Durham, North Carolina. It is my absolute pleasure to be chairing the first of 4 panels that we will have organized across 2 sessions today. This panel is focused on the topic of reducing harm and treating substance use disorder through COVID and economic crisis. We have 3 excellent speakers who are going to be sharing their experiences working in multiple different national environments, and some wonderful, wonderful discussants representing the European Drug Users Union and Recovery Uganda. It's going to be a great hour. I know we're all excited to hear the presentation, so without further ado, I am pleased to introduce our first speaker, Carmen Albizu Garcia from the University of Puerto Rico. Carmen, please, the floor is yours.
Research groups that came together, and it is on behalf of my co-authors that I am today exploring the impact of federal and state regulatory changes in this area of COVID as respects methadone maintenance treatment. Based on concerns for misuse and diversion, which is defined as the intentional medication dispensing or distribution through illegal channels, I'm sorry, the host has asked you to start my video. Are you not seeing my presentation?
Everything looks great now, Carmen.
Okay, thank you. Okay, let me go back. I'm sorry, I'm taking up time. Okay, and I just wanted to emphasize that take-home dispensing restrictions regulated by federal agencies in the United States have been in place since the 1970s, initially under very, very restrictive conditions, such that weekly 6 home take-home doses were only allowed after 3 years of good behavior and treatment. As illustrated in this slide, time and treatment, when accompanied by other eligibility criteria related to treatment outcomes, still places a burden on patients that are required to comply with daily supervised dispensation. Eligibility for 2 weeks of take-home doses is considered only after completing 1 year in treatment. These exemptions that in March of 2020 were issued by the federal regulators to avoid spread of novel coronavirus from patients congregating in OTP settings, in opioid treatment program settings, apply only to those states that concurred with the exercise of this exemption. It includes one blanket exception, whereas take-home doses are allowed for all stable patients after 60 days, and by request, up to 14 days of take-home doses for patients that were thought to be able to handle this safely. Providers' discretion applies, so that one of the issues that it has risen is because these are not mandatory exemptions. The reality is that the SAMHSA allows states and providers greater flexibility to dispense home medication, but it's not being utilized by all clinics, and that flexibility to its fullest extent is not applied across the board. This is reflected by press and other media reports that inform of patient congregations and OTPs across the country, of which the one shared in the slide is an example. Concerns persist among providers regarding safe handling of THDs, to the consequences faced in the event of an adverse outcome linked to medication diversion, and I identified in one of the studies simply to financial concerns arising from reduced treatment encounters that subsequently reduced income. We share lessons from 3 independent studies conducted, I'm sorry, okay, conducted in Tennessee, California, and in Puerto Rico that reflect on different social structural factors that influence take home. This includes the opioid treatment program financial payment structure, patients' housing status, and the situation that are faced in carceral systems by individuals receiving medication-assisted treatment. The first uh, this slide displays the main findings from the study conducted in Tennessee examining the experiences and outcomes of individuals with an opioid use disorder who received increased take-home doses from a for-profit OTP in Tennessee. It's important to note that the authors report that across both for-profit and non-for-profit reimbursement models, such as Medicaid, it is more financially favorable for OTPs to have patients come in multiple times per week to receive medication, regardless of clinical stability. And this structural factor highlights the need for reform of financial models to counter resistance for change from for-profit OTPs, which comprise in the United States nearly half of the OTPs nationwide. Our second study relates to the SAMHSA guidelines that mandate that people be able to safely store medications in their home environment if they are to receive take-home doses. This means that populations experiencing unsheltered homelessness and housing instability are excluded from consideration for take-homes. This study, conducted in an OTP in San Francisco, explores the impact of COVID-initiated housing interventions and on THD expansion. And it's very important to note that in San Francisco, take-home doses were enabled during the COVID-19 for qualifying individuals experiencing homelessness participating in a municipal program that transformed hotel rooms into housing. Now, this was basically targeting patients older in age with co-occurring health conditions who were much more vulnerable to morbidity and mortality from infection. Those individuals qualifying, interviewed by the researchers, expressed that they felt that they had benefited tremendously from take-home doses in terms of their recovery. It's interesting that providers who are well known to always be suspicious of anticipated adverse outcomes due to the fear of diversion acknowledge that these events did not occur, and that hotels actually allowed for safer storage and improved treatment engagement. This is important because it demonstrates the unintended consequence of temporary housing options in response to COVID-19 and how it intersected positively with stabilization of care in methadone maintenance treatment. Our third study talks about adjustments in the methadone maintenance treatment program in Puerto Rico prison system to avoid treatment interruptions and post-release disruptions in care. This is also very important because the majority of persons with an opioid use disorder in carceral institutions do not receive treatment. Individuals with OUD are overrepresented in the carceral system in the United States, which, as you all know, harbors the largest proportion of incarcerated individuals per population in the world. And reentering individuals with opioid use disorders are at high risk of non-fatal and fatal overdose events. In fact, a fatal overdose is the first cause of mortality among persons with an OUD reentering the community from prison in the first month. Methadone maintenance treatment is rarely provided in U.S. correctional institutions, and when available, restrictions imposed to curtail COVID-19 contagion may result in treatment interruptions. And this actually was documented in an article that surveyed treatment programs with buprenorphine in U.S. jails that revealed that due to COVID restrictions, they encountered challenges in maintaining adequate clinical staff and physical facilities to ensure social distances in these crowded environments. We share with you findings from the 2 methadone treatment programs that exist currently in the prison system in Puerto Rico, a U.S. territory. The programs were established in 2002. It was actually the first state prison system to initiate methadone during incarceration in the U.S. and its territories. The way that it functions is that the program is a medication unit of a publicly funded community opioid treatment program. And basically, the OTP is located in the same municipality as the penal institution. What occurs with medication units is that the OTP daily delivers and dispenses the medication at the medication unit. Upon release, the participants then are referred to that particular OTP regardless of the site in which they will be residing for continued treatment. In the event that this site does not provide geographical access from their site of residence, they can be then transferred to another OTP. As social isolation measures were enacted by the prison system in Puerto Rico in March of 2020 to curtail contagion, this precluded dispensation by the OTP staff, and weekly methadone dosages were delivered to prison and dispensed by the prison nurse. Other health services were sustained through telemedicine, including family therapies and other psychosocial services. As of September 2020, 3 participants released after sentence completion, and for the first ever time, take-home doses were provided on reentry. All participants attended the OTP to which they were assigned within several days, and at a 30-day follow-up, participants continued to engage with community OTPs and did not experience adverse outcomes from take-home doses. Data from the 3 studies suggests that take-home dose methadone access does not result in decreased patient safety. Attention to socio-structural context can offer critical analytic additions when assessing the public health implications of exceptions to take-home dose regulations. So basically, we think that this experience identifies factors that need to be taken into account when attempting to address the lack of access to take-home doses that precludes a patient satisfaction with treatment across many sites. As U.S. methadone policy is at a turning point, regulation exemptions should be normalized as overdose deaths are surging. To end the devastating and preventable U.S. overdose crisis, rather than reversing progress by returning to previous methadone regulations, policymakers and researchers should continue to study and learn from the natural experiments created during the pandemic, of which our experiences are a contribution. We need to close the existing treatment gap, which is really large, by providing drug treatment structures that prioritize evidence-based and patient-centered policies, particularly since most people with a substance use disorder in the prison system either do not receive any care, and if they do, it is oftentimes just a group therapy that has a lot of issues in terms of dangers that it can pose in a prison environment. So basically, we are hoping that as we continue to provide evidence about the successes with the exemption measures that have been established, we can also prioritize evidence-based and patient-centered policies and clinical practices to address the unmet need for care.
Carmen, thank you very much. I apologize for interrupting. We do need to move on to the next speaker. May I invite you to offer any last thoughts before we?
Yes, this is our last slide. It
Thank
basically
you.
is to share with the audience that there are efforts underway from federal agencies to increase access to medication in prison, and that we really urge financial support initiatives for for-profit programs that ensure a restructuring so that providers are reimbursed based on overall provision of care as opposed to methadone dosing to avoid restrictions in take-home doses. And with this, I thank you very much for your attention and welcome the opportunity to participate in the discussion section.
Carmen, thank you so much for this wonderful presentation and for your grace and patience with our very tight scheduling today. This is such an important part of the conversation about methadone reform that's going to be continued in our second panel by Katie Simon and Abby Coulter from the Urban Survivors Union. Before we get there, though, it is my absolute pleasure to introduce our next speaker, Ramin Radfar from Tehran University of Medical Sciences in Iran. Please.
Thank you very much. Let me share my screen. So do you have my screen now?
Yes.
Okay. Good evening, ladies and gentlemen. Thank you for all of the support that you conducted for having such a wonderful webinar. My talk is about how substance use treatment services in Iran survived despite a dual catastrophic situation, in which I will say that what are these situations. First of all, let me say that authors declare no conflict of interest, and more important, authors at the paper, is my colleague, Dr. Farhoudian, and me, and the presentation have no political view on etiology of the sanctions against Iran. Here, the authors only provide impact of the sanctions on health system and different mechanisms based on the published documents. Let me put me a little, please. Okay. The sanction. Let me have a brief history on and impacts on Iran. First wave of sanctions against Iran started since the Islamic Revolution in 1979. It was at that time mainly from the US and because of the political challenge and issues between two countries. Later, in approximately past 2 decades, many other sanctions established against Iran by the US government and or United Nations and maybe European Unions, and it was only mainly because of the nuclear activities of Iran. A considerable number of the sanctions was lifted in early 2016 when Iran signed the JCPOA in 2015, which we called it Barjam in Farsi, and nowadays the negotiation and talks for re-establishment of that is ongoing between United States, European countries, and Iran. But during the President Trump's administration, the policy of maximum pressure strategy adopted by the United States, and the United States announced its withdrawal from the JCPOA and reinstitute more sanctions in May 2018. I would say that these sanctions were much larger than all of the other sanctions that we already had. Sanctions against Iran violated the health right of the people by compromising their access to adequate food, health services, and social security. All of them because of the economic impact that ultimately was the desired impact of any sanctions against any countries. In 2018, after renewed US sanctions, Iran GDP declined from 4.8%, declined about 4.8%, and the inflation rate increased from 9.6% to more than 30% in 1 year, and it's ongoing now. Still, we have much more inflation rates every year. There are many studies that showed negative effects of sanctions on health service in Iran at the general population, children, and patients suffering from cancers. Even publishing research papers and other research collaborations experienced negative effects during the sanctions because of the problems in money transfer or something like that, and many other problems, and many publishers now officially refuse to publish Iranian papers. Regarding the COVID, what is the situation in Iran? What was the situation actually? Iran was one of the first countries after China which reported the first case of COVID on February 19, 2020. And a few weeks after that, this is when I say this is in the domain of the addiction treatment. Residential addiction treatment facilities were closed, and mandatory facilities also were closed. Personal protective equipments and COVID-19 education pamphlets were quickly distributed to harm reduction centers in large cities. At that time, the demand for harm reduction centers, harm reduction services increased for a short time because many of the substance users who were in the mandatory or compulsory treatment systems released to the streets. All 12 steps anonymous groups and other self-help groups transitioned to virtual meeting, and let's see what happened in other domains, means the treatment. In the mega level, when we say substance use in treatment, in the strategy, treatment services, harm reduction services, and self-help groups. At the treatment services, in the residential settings, residential facilities first closed, but very soon after the protest of the people in the streets that why these homeless drug users are so much in the streets or in the neighborhoods, then later they reopened with the new rules to reduce COVID-19 transmissions, including social distancing, screening, and COVID-19 testing for clients. They put a quarantine process before going to the main campus and started to work as usual. In outpatient and OST services, as you know, clinics were authorized to provide larger take-home supplies of methadone, buprenorphine, and opium tincture for their stable patients. And in harm reduction services, personal protective equipments and COVID-19 educational pamphlets were quickly distributed to harm reduction centers in large cities. New strategies also adopted for coping with new challenges, such as lockdown situation of the parks. For example, usually the people, substance users were going PWID or PWUD, goes to park to use water closure services or taking the clean waters. But during the lockdown, even the clean water were not available for them. So providing the clean water was a strategy. And actually, it was a challenge in large cities, actually, I have to say. For the self-help groups, all 12 steps anonymous groups and other self-help groups transitioned to virtual meetings. But how, despite the economic crisis due to COVID and sanctions, did service maintain? We would like to categorize this etiology for this in 4 domains. One of them is that large network of service providers. Another one is maintaining low cost of services, being flexible in take-home dose and opioid drug delivery, and reducing the need for harm reduction services. Let's see, when we say large network of service providers, what does it mean? In Iran, there is a high demand for treatment services. Actually, more than 7,000 OST clinics are established in Iran. They are mainly in private clinics, but also some governmental and in harm reduction services. They provide MMT, BMT, and also maintenance treatment with opium tincture. Because of this large market, infrastructure for domestic production of opioid medications such as methadone, buprenorphine, and opium tincture was already established in Iran before the sanctions. So means that we have our domestic opioid drugs. Maintaining the low cost of services is another problem. Overall cost of the health services in Iran is very low. And this is in the domain of the substance use treatment, it is much more lower. MMT much less MMT is much less expensive than illegal use. Usually, maximum 4 or maximum 7 days of the substance use is equal for 1 month in treatment for MMT or BMT. MMT is cheaper, but BMT also is cheap. A local opium tincture manufactured used seized opium, which makes its price much cheaper and it's much more available. As you know, we are we have a long border with Afghanistan, and hundreds of tons of opium every year seized by the Iran police. Those who has a good quality will be used for opioid for making opioid tincture, opium tincture, or other opioid drugs. And even before the onset of the COVID-19 pandemic in Iran, MMT patients were able to get their take-home dose from the clinic shortly after induction. When I say shortly, it means that the maximum 15 days. For the buprenorphine and opium tincture, it's about 7 days. So even before that, we had a very flexible take-home dose strategy. During the COVID-19, it was much more flexible. We could give to the people for about 28 days or even more regarding the buprenorphine. And the authorities dismissed the need for signature or thumb fingerprint of the patients, and because of having less contacts. And because of the availability of the opioid maintenance medication in past years, the number of PWAD decreased, and impact of this is seen in the reduced prevalence of the HIV among PWAD in Iran. Years ago, we started our harm reduction activities in a very large scope, in both closed setting and open settings, from the 2003 or 2004, and after that we had a very large growing up harm reduction services. But by when the MMT clinics, OST clinics established in this large scale, the number of the PWIDs decreased day by day. And for example, this is a study recently published in 2010. The prevalence of HIV among the PWID in Iran was overall 15.1%, and now in 2020 it reduced to 3.5% among PWID. Both study has been conducted by the same methodology. So this was what we could pass this situation. Thank you very much.
Thank you so much. I can't overstate just personally how marvelous this particular collaboration has been, because I've had the opportunity to learn so many things from so many extremely talented and experienced practitioners in different regions, and y'all are just getting a taste of it. So it's my absolute pleasure to introduce our next speaker, Dr. Tatiana Kiriazova from the Ukrainian Institute on Public Health Policy. I should extend our special thanks to Tetiana because she is joining us very, very last minute. And so she will be coming on screen in just a moment to join in a sort of brief conversation. So what we're able to do at this time, since Tetiana was given extremely short notice for joining us today, is to have, I'll be asking her a few questions about the situation in Ukraine. So Tatiana and I, as well as Karsten Lunza, who's with us in the audience, and several other collaborators, were able to contribute a piece to this particular issue of the American Journal of Public Health on substance use treatment and harm reduction in Russia, in the Russian Federation. But Tatiana's expertise also falls in Ukraine, and we're really hoping to learn a bit from her. Tatiana, how are you?
Fine, thank you so much. Thank you for inviting me.
Thank you so much for making the time to be with us with so many other things going on. So in the interest of full disclosure, I know Tatiana pretty well, and I know that she knows the answers to a lot of the questions that I'm asking. But I'm hoping that you can just begin by telling us a little bit about what MAT looked like in Ukraine. I do know that both methadone and buprenorphine are available in Ukraine, that these treatments began in the early 2000s, and in 2016, the government of Ukraine really took over financial responsibility for these programs from the Global Fund. Can you tell us a little bit about what MAT treatment looked like in 2019, 2020, before COVID-19 began?
Very quickly, you're absolutely right, Jen. Buprenorphine appeared in Ukraine. The first program was buprenorphine in 2004, and then we got methadone treatment in 2008. And as methadone is cheaper and it was more available, more widely available, we switched mostly to methadone, and only less than maybe 10% of people stayed on buprenorphine. And it was initially mostly the population of people, of HIV positive people. And very slowly, and absolutely not enough numbers, the program was expanding since 2008, and as you said, till 2016, we had less than 10,000 of people of estimated number of 330,000 of people who have opioid use disorders. So it was even less than 3% of people covered with OAT program. And in 2016, because there were like, from one side, it was not enough spots, places in the narcology dispensaries, as in our country, the governmental free program, OAT program, is available only in the state medical facilities. And mostly these are like narcology clinic, narcology dispensaries. And in each region, people, it's very much depends on the leadership of the regional authorities, medical authorities. Because, for example, almost the same numbers, estimated numbers in Dnipro and in Odessa region, and in Dnipro region we have about 40, I think, MAT sites, and in Odessa it's about 7 or 8 still. And there are districts where methadone is unavailable. And still there were like lines, and preference was made to the people who are HIV positive. At the same time, people, and you know this probably better than I do, people have lots of prejudices and myths regarding OAT. Sometimes people still think that using street opioids is better for your health than start OAT, because this is forever, you can't quit, etc., etc. And so altogether really got us to the situation when the expansion was slow. Since 2016, the government, like with years, and there were during several years, government completely took responsibility of providing methadone. And I think that people who were in treatment, they maybe didn't even recognize this. They could see only the medication itself, because in this 2015, 2016, our national producers, 2 plants, manufacturers in Kharkiv, you know, Kharkiv, which is now suffering just genocide.
Being devastated.
Unbelievably, yes, difficult humanitarian crisis. And Odessa, which is more or less quiet so far. And these 2 plants, they were producing methadone and buprenorphine. And we practically we stopped distributing imported medication, which was considered to be like of better quality by some people, like Canadian methadone. And it was enough medication. And since 2019, actually, the national strategy of addressing HIV/AIDS, TB, and hepatitis C epidemics in Ukraine, they put a very ambitious indicators for us, like aims, objectives. So we were supposed to cover with OAT treatment 15% of the estimated population of people with substance use, opioid use disorders by 2025, and 40% by 2030. So it was about 5,000 to enroll in the program every year. And by the end of 2021, we were not far, but we are rather far from fulfilling this, from meeting these indicators, but still program is available. Buprenorphine became available also as widely as methadone. And before the beginning of the war, the program was expanding, and there was no problem of enrolling into the program.
So
before
COVID. Go ahead, I'm sorry, please.
COVID, yes. COVID was, of course, unexpected to everyone and to our program too. And when COVID appeared in like beginning of March, we started widely speak about it. And from the mid-March to the end of May, we had a serious lockdown, like national lockdown. And this lockdown really impacted the access to the harm reduction services, which were available but shrinked. These disease of the transportation, people were not able to use public transportation. And unfortunately, in many cities, for example, in a city of Kyiv, with 3 million population, we have actually 4 or 5 methadone sites, witty sites still. And so people definitely had to get there. And without transportation, it was unavailable. And many people switched from, and the same with stashes, with street methadone. And many people switched from street drugs to these private, to getting drugs for money, to getting paid methadone from private physicians, private clinics, private cabinets, etc. And many of them wanted to start actually treatment program, pre-governmental treatment program. And during this time, we were able to keep all our patients, because if before, like only 60% were on take-home doses, during this lockdown, practically all patients were switched to take-home doses. All of them started receiving methadone for 10 days. And of course, it was much easier for them. And after the lockdown stopped, actually, we have almost 80 or 90% of people in some sites who stay on take-home doses.
Yeah, that's really amazing to hear.
The problem was that we didn't enroll new patients during lockdown. So this is how the COVID influenced, but we kept our patients with us. This treatment was available.
Thank you so much. So we have only about 1.5 minutes left, and I want to make sure that we touch on Russia's war in Ukraine. And I know that they don't call it a fog of war for nothing. It's sometimes extremely hard to know what's going on or what the situation is. Are you able to share anything with our audience about the situation for people who are receiving opioid agonist treatment with methadone or buprenorphine in Ukraine? And we have a minute left. Yeah, thank you. I know people are very curious.
Of course, you know that it depends on the region where people were receiving the methadone. For example, if the region is occupied or under heavily missile shooting, like Kharkiv or Chernihiv, for example, or Kherson is occupied, or Mariupol, you know, this is really humanitarian catastrophe. And we don't have, for example, connection with people from Mariupol for the long time, for more than 3 weeks. But even in Kharkiv, I mean, our medical workers are our heroes. Even in Kharkiv, people are still receiving methadone. And in different regions, there are supplies of methadone and buprenorphine from 1 month to 5 months. And now we are doing a great work redistributing, you know, the methadone from better supplies, from the regions where there is better stocks, more stocks, to the regions, for example, to Sumy, to Chernihiv, to Kharkiv, to Kyiv region. And our plants are not operating now. And we understand that we really need humanitarian aid from our international partners. We hope very much for the Global Fund. But as our public health center, who is responsible for supplies of MAT, they are governmental organization, bureaucratic, and their procurement procedures are very slow. We hope very much that our partners through, for example, Alliance for Public Health or other people or other organizations, they will be able to receive new supplies of these medications, or else we started a little bit decreasing our doses in some regions, and many people actually moved to the Western regions. For example, in Lviv, they said that their numbers increased, the number of patients increased by 70%. So people were able to move. Some of them left the country, but very few of them, you know, these are not very mobile population, but still some people left, like flew from the really hit by the war regions to the safer regions of the Western Ukraine and are receiving methadone there. But of course, our national supplies need to be
Restock.
supported. Yes.
Yes, Tatiana, thank you.
International partners. Thank you.
Thank you so much for taking the time to talk to us. And I want to very briefly echo your statement that community health workers, healthcare workers, and harm reductionists in Ukraine have been out of this world for the last 20 years, honestly, but for the last month, especially so. And I recall when Russia first invaded Ukraine in 2014, the administrative action was taken to close all methadone programs in Crimea, simply for political showmanship. And a lot of people died. A lot of people died. It was really hard to even understand
10%.
how people, honestly, it was only because Igor Kuzmenko from Input posted a video that I learned that my friends had died, because we had no news and no updates. So I'm just really grateful that you took the time to speak with us, and дуже дякуємо. Слава Україні.
Героям слава.
Yeah, thank you. All right, Tetiana, thank you so much. And I am pleased to bring us now to our fabulous discussants, which I think this is going to be my favorite part of this panel. So our first discussant is Daphne Chronopoulou from the European Drug Users Union. Daphne, thank you so much for joining us today.
Hello, thank you for having me. I would, I'm already, excuse me, let me close the door because my dog is barking.
Thank you.
I apologize for this. Anyway, I have found very informative all I've heard, and it's very close to what our experience in Euro Input as drug users, going in the streets, helping our peers, what we have experienced. COVID restrictions created many problems and brought many changes, paradoxically. The problems were that, not all methadone or OST users are in a program. In many countries, our people are not, or in many places, our people are not in programs, but buy methadone or buprenorphine in the streets. So black market was really hit very hard by the restrictions, and also the drug supply became very restricted. So people were in danger of ODs because they didn't know they lost their regular dealer. Our women, we have some women who are sex workers, especially in Spain and Portugal. They're very well organized. They have some women's group very strong. They were complaining that as they couldn't work, they didn't have enough money, so they were much more vulnerable. So from the one hand, it was very tough for us. I remember I was very proud in the beginning that in Europe, we were the first who created this leaflet for safe use during the pandemic. And we circulated in all the countries that we have peers. On the other hand, many programs in many countries in Europe took the decisions that I heard about, that it's global from what I heard before, to give take home to people to whom they wouldn't give otherwise. And it was discovered that we had no abuse, that it worked perfectly. And we are fighting now to establish more take-home opportunities to people who are in substitutes, because I believe psychologically it's very important. Prohibition makes our people be connected to the black market very often, even people who don't want, even people who don't have gain from it, but they have to do it. And during the COVID restrictions, it was really hard for some of our people who use drugs, and for people who never used, who were in programs, but suddenly could not travel to find their medicine, could not buy it in the black market. The streets were empty. Opportunities for petty crime, which we have to admit for some of our teams, for some of our people, is a way, especially the women I work with, the Medicineres and the GAT from Italy and Spain and Portugal, they were saying openly that we have no clients, we're sex workers, what can we do? We're terribly poor at this moment, we need some kind of support. So what I wanted to say is that we took two lessons. For us, it's very clear that take-home works. And the other lesson is that peers had to step up because the state was occupied by the serious cases of COVID. Clinics and hospitals were full, doctors were occupied in other things, finances were very restricted. The peer organizations had to step up and go in the streets and try to distribute sometimes black markets, OAT, OST, but we did. And the lesson is that we had more response than the response given from the people who are in the streets to workers of NGOs who do not know how to speak, who are not trusted, because our communities, the most vulnerable people of our communities are the people who do not trust authority. They have very bad experiences with it. So having somebody who uses the street language, who has the same experiences, helped a lot, and we saw many changes. And what I wanted to say is that listening to all that was said before, I was impressed that more or less in very different situations and circumstances, in absolutely different countries like Europe, because Europe is a huge spectrum of countries like Bulgaria that is very dangerous even to write about drugs, or countries like Portugal where it's free and okay so to use, and you can use in the street and have a party and write about it and speak about it. Even in this wide spectrum, we saw that peer work and take home work and help us prevent ODs. And I didn't mention naloxone, which also is something very important. It's absolutely ridiculous that we don't have a huge supply of naloxone in the streets, in the pocket of every drug user. I'm Greek. I fight for it because in my country it's not readily available, and I'm very angry about it. I'm trying hard to convince authorities and lawmakers to really make it. So, okay, we distribute it illegally sometimes, but we did. And this helped, and we had much less deaths in our community during a pandemic than we usually do. And this is very indicative against prohibition and about how useful is peer work and peer connections.
Daphne, thank you so much. I apologize for interrupting you. We are at time and need to get to our next discussant. I'm so grateful for your comments and for your anger and your enthusiasm. It's so feeding for me. Thank you. Thank you. It's my pleasure to bring us now our final discussant, Sarah Namirembe from Recovery Uganda. Sarah, thank you very much for joining us today.
Okay, well, thank you so much for inviting me. And I'm Sarah from Uganda. Let me give a brief introduction about Uganda. For this is going to help us understand the perspective I'm coming in with. Uganda is, and I think it's one of the countries with the least budget allocation towards its health sector, and without a catastrophic budget, both at an individual level and also government. So you find that during the pandemic, everyone, just like how it was in several countries, different people were having, different people were going through challenges. And among the people who had challenges were the people with use disorders. So you find that among these people, they faced, of course, structural barriers, and some of them were because of accessibility to treatment. Others couldn't have, there were financial issues. They had several issues among others. Some were housing and so many others. So now, another thing is Uganda, we have a biomedical hegemony whereby treatment is thought to be based in treatment centers. Unfortunately, we have only one national hospital that can help, but we have so many mushrooming rehabilitation centers, which are extremely expensive. During the pandemic, people with use disorders had to suffer a lot. But here I'm coming in with another perspective. And here I'm citing a social contrast to what happened. So biomedicine, the treatment centers and all that, you find that Ugandans resorted more to other alternative modalities of care. And these include herbal therapy, it included Pentecostalism, which is maybe evangelical, and they also used the traditional indigenous healing. So during this time, these people who remained in these other modalities of care, for them, they thrived. Actually, they transitioned smoothly with, they transitioned smoothly through the pandemic, because therapy in these among these therapies, that for them, they were having a person-centered, or can I call it a person need-centered approaches to care. These people, for them, they could help provide food. They could help provide social interactions. They kept the relationships intact, and also they provided housing. This wasn't because maybe, but this was on an individual level whereby people could help each other. This one could wonder how it did happen, but I think because us being with a social and cultural fabric which is still intact, I think because we are still among the LMICs, I think this helped a lot. Unlike for people who were using treatment centers, people in treatment centers, for them, most of them actually relapsed because they couldn't afford care. Others couldn't access care because of the restrictions. Yet these other ones, for them, meant to help. So I think as I finish this, what I got from this, maybe the lesson, the take home is the social connectedness during this time was so important, and this helped many people using opioids and alcohol transition smoothly through the pandemic, and also the patient I call it individual-centered therapy. The need-based therapy was really great, that these people actually thrived. So I think that's all I can say at the moment, unless there are questions. Thank you.
Sarah, thank you so very much. It's wonderful to hear from you and learn about your experience in your community. I'm exceedingly grateful. I have been given special dispensation, even though we are slightly over time, to turn one of the questions from our audience to one of our speakers. I will remind our audience that there is a Q&A function. If you're able to access that, many people have been interacting and typing responses to questions there. Please feel free to interact with the speakers and panelists at that point. But the one question we had was directed at Ramin Radfar, and it was about the use of seized opium to make opioid tinctures as a treatment medication, substitution medication. The audience member was curious whether or not you might recommend that policy to other countries while criminalization continues, ostensibly while opium is still being seized from community members. And I'm curious, what happens when criminalization stops, if we can allow ourselves to ask that question?
Actually, let me say some things about using opium tincture as a maintenance drugs. Means that usually we use the drugs for maintenance with a long half-life. For example, for methadone, such as 24 hours to 48 hours. Buprenorphine by the 60 hours is its half-life, and for the opium it is much more lower, about 4 hours, something like that. And so this makes opium tincture is not a good medication for maintenance treatment. But on the other hand, there are some pros for this. One of them is that the induction phase is very short, means that by the 24 hours or 48 hours, you can pass the induction phase of the treatment, so that you can find how much is the stable dose of your patients. This is very good, important. And also another one is that for those who are still seeking for getting high or being more euphoric than what what methadone can give them, opium tinctures can make them much euphoric, exactly such as oral opium. It is actually the quality is much better than the opium in the street, because it's purified by the pharmaceutical companies. So this is the pros. The cons is that still the positive test is morphine positive test is positive, and also and for the other countries, if they have these drugs available, means that if they, that Iran usually has more than 100 tons of seized opium each year, so it can produce it. Many of them. So if another country has more than 100 tons and has this precursors, yeah, sure, it can be used for those who want to continue using drugs. This is a very, very, very pragmatic approach. Or for those old patients, for example, 70 years old patient, 80 years old patient who is using opium for last 40 years. So we don't want his role as a grandfather or grandmother using opium in front of his grandson or granddaughter. So it is very good because we are using a medication for it.
Fabulous. That's so interesting. So it sounds like, in the way that in the United States, many of us think about like methadone treatment, for example, as both a treatment and a safe supply, it sounds like opium tincture might be more safe supply and less an effective treatment, but it's a different way to kind of get at these. This is so fascinating. I'm so glad that I was able to ask this question. Thank you.
Thank you very much.
I want to extend again my sincere thanks to all of our panelists. Audience members, please stick around with us. This afternoon, we're going to be having panels on social and racial inequities, international advances in harm reduction. But first, I get to hand you over to our incomparable colleague, Caroline Parker, to lead us through our next session on medication and substance use disorder policies and practices that promote health justice. Thanks, everyone.
Thanks, Jennifer. I hope everyone can hear me. I'm Caroline Parker, your chair, and I'm delighted to invite you to the second panel, Medication for Substance Use Disorder Policies and Practices that Promote Health Justice. We have some really awesome presenters today. We have Caty Simon and Abby Coulter from the Urban Survivors Union. We have Trang Nguyen from the University of Hanoi. And two of our discussants will be Anne Vemley and Andrea Lopez. But we will also try and make sure we have some time for some Q&A at the end. So without further ado, Caty and Abby, would you like to take it from here?
Yeah, can I share the screen now? Oh, there we go. Okay. All right, one moment. Hi, I'm Katie Simon, a leadership team member of Urban Survivors Union, USU, the US National Drug Users Union. USU is made up of over 30 chapters and affiliate groups, including drug users unions, drug using sex worker-led organizations, and other drug war impacted groups. I'm first author of our methadone team's editorial in this issue. In this editorial, we draw from the Methadone Manifesto, a living document we produced during COVID in response to treatment difficulties that we and the people we advocate for experienced. Methadone is heavily regulated, creating multiple barriers restricting its effectiveness, though it's considered one of the best ways to reduce fatal overdoses and other harms of criminalized opioid use. Methadone regulations were relaxed during the pandemic, as you heard in other presentations, but we observed many clinics were not relaxing policies and member overdose rates were increasing. COVID was altering illegal market infrastructure, increasing our reliance on potent synthetic opioids and poisonous adulterants. This project was inspired by our struggles at clinics during COVID. For instance, one member's clinic restricted her to a low dose. To avoid withdrawal, she supplemented her dose with street opioids she knew were contaminated. She said, "I'm meeting with the State Opioid Treatment Authority every month, and they're watching me die in real time." While she was hospitalized because of drug poisoning, we created the manifesto. In the manifesto, we highlighted methadone research gaps through our experiential knowledge, outlined how certain policy and clinic practices don't align with patient needs, and proposed solutions for treatment reform. There's a long tradition of using experiential knowledge to advance research in critical race and disability studies and many other disciplines. Sharing our experiences exercises authorship over how scholarship describes us. We developed the manifesto using our model of community-driven research through literature reviews, interviews, and autoethnographic accounts from team members, weekly 2-hour meetings, and group conversations and texts based on collective lived experiences. USU supports broader buprenorphine maintenance treatment, BMT, especially eliminating racial and socioeconomic access disparities. However, we focus specifically on methadone because although BMT poses fewer reg hurdles for many of us, BMT doesn't work, but methadone does. For example, BMT induction can be traumatic. It requires severe withdrawal and risks precipitated withdrawal. And as fentanyl analogs replace heroin, that risk has increased. BMT patients whose goal is moderation also risk precipitated withdrawal using other opioids. Finally, many BMT patients report never feeling free from withdrawal. So in the absence of legal, safer, short-acting opioids in the US, methadone is our safe supply, as we say. Oh, sorry. I'll briefly cover 3 topics in the editorial: problems during the pandemic, take-home dosing, and patients in the sex trades. Many of us have high COVID hospitalization risks because of comorbidities. When SAMHSA relaxed some methadone restrictions, we were relieved. But many clinics didn't increase take-homes or only provided a few. They said they feared diversion or that we needed the stability of in-person dosing. Many clinics revoked increased take-home doses within months, saying they couldn't fill so many take-home bottles or that we needed to prepare for take-home increases to end. In spring 21, some clinics and state bureaus stated increased take-homes were unnecessary with vaccination available. But many patients are low income or BIPOC, hit harder by COVID, vaccinated at lower rates. Research shows in-person dosing does not decrease illicit opioid use, diversion, or mortality. Lockbox and bottle return requirements create more barriers. Take-home dosing increases retention and helps maintain employment. Studies on COVID regulation relaxation showed no increased fatal overdose and little self-reported diversion. We recommend policy and program changes, including not requiring negative drug tests for take-home dosing, limiting lockbox and bottle return requirements, and making COVID relaxations permanent. We discussed the challenges of many marginalized patient populations. I'll briefly touch on our work on patients in the sex trades. These patients are under-researched and yet vulnerable in so many ways, as we detail in the manifesto. For example, experiencing higher rates of incarceration and low methadone retention. Patients in the sex trades often miss doses because of limited clinic hours. In our experience, methadone counseling can be a hostile environment for sex workers. Counselors can urge them to quit sex work before they're ready or disqualify them from take-home eligibility. People are afraid to disclose in group counseling, fearing stigma and advances in abuse from patients and staff. We recommend broader hours, sex worker cultural competency training, and voluntary sex worker only support groups. And now I'll turn it over to my co-author, Abby Coulter.
Good morning. Thank you, Katie. So I'm going to start out just with a little bit of an introduction. I'm Abby Coulter, and I want to start by briefly touching on our methadone advocacy efforts and patient experiences that brought us together in collaboration, making the work on the Methadone Manifesto possible. I, too, am a member of Urban Survivors Union, where I'm also a methadone liaison. I have the privilege of working at NCSU, the flagship affiliate of Urban Survivors Union, where I hold the position of Special Projects Coordinator, where our team continues to focus on methadone and the varying intersections within the methadone system. It was my own experience as a pregnant and parenting person on methadone that led me to life as a methadone advocate. Many of us at Urban Survivors Union have spent decades doing advocacy work, both formally and informally. In developing the manifesto, it was those collective experiences as both advocates and patients ourselves that we drew from. As the COVID-19 pandemic hit and we were forced into virtual existence, methadone advocates from across the country began coming together in collaboration. It was clear that the Methadone Manifesto would be the focus of some of our efforts, a way to not only call out the issues, but offer up real solutions from those of us who are directly impacted by those very issues. In developing the manifesto, we drew from the collective advocacy experience that many of us at Urban Survivors Union have decades of advocacy experience for. Every sentiment and issue, every solution or proposed idea for improving the current OTP system written into the manifesto was drawn from the hundreds, if not thousands of people on methadone that we were able to reach. The work we continue to do on the manifesto as a living document comes not just from our experiences doing national organizing on this work, but also continues to be fed by our observations from the ground as patient advocates and patients ourselves. Next slide, Katie. So from our work published in the supplemental edition of the AJPH, I'll be highlighting some of the focus areas for you this morning. And where better to start than drug screening and the fact that this practice is an indicator of a system built on control and regulation as compared to health, dignity, and respect. The reality is that when punitive measures are tied to therapeutic or clinical services, they're dangerously ineffective. Patients should be treated based on their behavior as a whole, not based on the chemical content of their urine. In our experience, punitive measures based on toxicology do not result in positive outcomes. And urine screening often creates hostility towards patients on the part of clinic staff. This includes counselors, nurses, even your front office or financial individuals. Screening precludes authentic therapeutic relationships between patients and staff. Next slide. The next topic area I'm just going to briefly touch on is parenting patients. But before we do that, I do want to just touch on pregnancy and methadone. We know that methadone is the best and safest option for people with opioid use disorder during pregnancy and breast chest feeding. Its ability to prevent withdrawal symptoms helps pregnant people better manage problematic opioid use while avoiding health risks to both pregnant people and their babies. The focus on resources for pregnant patients is so important and necessary, and not only for the health of baby, as most OTPs in our experience solely focus on, but for the pregnant patient as well. Moving into the next area naturally is parenting patients. Parenting patients receiving methadone maintenance make up a significant part of the MMT population in the US. With this group of individuals come very specific and unique needs for access to MMT. Unfortunately, these needs are really often underprioritized within OTPs, or opioid treatment programs. Parenting patients face barriers such as transportation, childcare, and family court and child welfare cases. Parents' needs are rarely recognized by MMT programs, and these needs are usually only addressed during pregnancy. For instance, payment can be deferred during pregnancy, but will usually be made due postpartum. This often results in MSWs, or what we often call financial detox. Some facilities don't allow children on site, causing issues with treatment retention once again. And there's a long history of violation of the reproductive rights of people who use drugs, especially people who use drugs of color. And that's exasperated by the practices of some clinics. Next slide. Our next area of discussion quickly is patients and relationships and treatment. Many of us who attend MMT programs do so with others we have existing relationships with, whether they're platonic, familial, intimate, or just relationships of convenience. This plays a significant role in our lives and our treatment as well. In our experience, patients are often punished by association. For instance, a positive screen for one partner causes the other's take-home doses to be rescinded. Confidentiality is often violated when patients are punished for the actions of patients they're associated with.
Hi, Abby.
Hi.
Hi, thank you. You know, this is such interesting material, and thank you so much for talking. I think we can maybe return to some of the pieces that we haven't had time for just now in the Q&A. So
that's okay. I'm at the this is my last slide, so that's perfect.
Oh, okay,
and
wonderful.
It just touches briefly on some of the things that we're going to be continuing to work on.
Wonderful. Well, thank you so much, Abby.
Thank you.
It's been really inspiring hearing the work you've been doing, and thank you for speaking so frankly and so openly. And so without further ado, I think we can go to our next speaker, which will be Trang Nguyen from the University of Hanoi. I'm really looking forward to see what you have to say today, and yeah, take it away.
Sorry, do you see my slide or not?
Not yet, just you.
How good is it?
Yeah, that's great. So you have 10 minutes. Thank you.
Thank you, Caroline, and thank you for the organizer for inviting me. My name is Trang Nguyen, and I'm from the Hanoi Medical University. And actually, because our today our panel discussion focus on the medication for SUD, so that I would like to make the case of the methadone treatment in Vietnam. Here you will see a bit of the overview of the substance use situation in Vietnam, that actually the drug use became illegal since our renovation in 1986. So at the time we opened to the international trade, and then at that time there are increasing number of heroin user, and then the syndemic of HIV and injection drug use became important, and that leads to the first penalization and then compulsory rehabilitation in Vietnam. So with that, we go to in the early 2000s, we have the methadone maintenance treatment introduced into Vietnam, and this had led to a significant shift in the Vietnam drug policy, and it introduced the harm reduction approach, and also the decriminalization of personal drug use. However, we also see that very recently with the with the emerging ATS or methamphetamine use in Vietnam.